Hi, Mugni.
Hi, good evening. How are you?
Good, thanks. You well?
Good.
How are you? Good. Dr. Anof just sent in her uncle's in hospital. She'll try to join, but she apologizes if she can't make it.
Okay, we've got 4 attendees linked in by the looks of it for the moment. Do you have a presentation to share, Novat?
Yeah, do you want us to go ahead and I think I'm seeing
So a few more. We've got 6 attendees so far.
So I think, should we go ahead and start? What do you think?
Yeah.
Okay. Well, good afternoon, everybody, and hope you can hear me and see my slides. Remember, we want this to be as interactive as possible because this is the last episode of the series. And then during the actual conference in Jeddah, Saudi Arabia, the SASA studio, there's a session on intracoronary imaging where Tom and Mukna and the rest of the team are going to be showing more cases, and it's going to be very interactive. So please do join. What I'm going to do is do a very quick recap. You know, we've done MLD in the past episode. Today our focus is going to be MAX. And MAX, really, we're going to be focusing on medial dissection, apposition, and expansion, and kind of understanding what each of these means and what are the actual criteria. Remember, imaging is going to give you a lot of information, but it's important to understand what is actionable. So if we start with the medial dissection, so what you do want is to look at what is considered a significant dissection, right? So you want something that is going to go beyond the media and greater than 1 quadrant. So if you look at this one, this is the first image on the left. This is just restricted to the intima. The second one is actually extending deeper into the media. And the third one is now not just a dissection. Now you're talking about a hematoma that you can actually see. Then there's apposition. So you, again, when you look at apposition, you may see a little bit of malapposition. What is actionable? That's what you need to always ask yourself. A lot of the automated systems now will give you, they'll give you detection of malapposition that is automatic, and it'll actually give you dots like this over here that actually shows you how much malapposition there is. So generally, when there's gross malapposition, so it's more than 3 millimeters. So if you look down here at the longitudinal display, if you start to see that it's extending more than 3 millimeters, and then it's extending from the wall, so the distance from the wall is more than 3.3 millimeters, you know that that's significant. And again, you do have your calibration. So if you look around 3 o'clock, that's quite borderline. But as you start coming down around 5, 6 o'clock, that is significant. And then there's the stent expansion, right? So we talked about it last time. What's acceptable is 80%, but ideally you want to reach more than 90% because that's what's considered suitable. And then again, the automated systems will actually give you how much expansion there is. So when you're doing post PCI, post stenting, so now you've done your PCI, you've identified the morphology, you've pre-treated the vessel, you've done your referencing where you're going to start and deploy your stents and then actually deploy it. Once you're done, this is the part that comes in the MLD that we're going to look at. So again, remember, more than 90 degrees involves the media and distal edge. This is the M, apposition. Remember the rule of 3, and then expansion. Ideally, you want to be more than 90%. And we did talk about it in the very first episode that it is related to major adverse cardiovascular events. So this is the European document that's actually available online, and it'll actually give you the references for all of these that you can look at. So I'm going to show you a case very quickly, and then Muqna is going to go over some multiple choice questions that are going to be very nice and fun and interactive. And then we're going to go over a case where Tom is going to actually walk you through the analysis. But I want you to see this case because this happens. So what you do see, and again, please feel free to interrupt me. So you do see, this is an areocranial shot. You see a very long diseased segment of the LAD, and it starts to get into normal around the mid-LAD, somewhere around here. So we did intracoronary imaging, and as you go along, you start to see a little bit of calcium, right? But not that much calcium, but you do see, as we keep going down, you see again more calcium from around 11 to 1 o'clock, and then deeper calcium from around 3 to 6 o'clock. So there are different types of calcium. There's superficial, there's a bit of deep calcium, but not a whole lot. And some very fibrotic segments as we're moving more and more distally. So we end up dilating. As you can see here, the balloon did not yield. There's still a waste. So we take a cutting balloon and we do some more cutting. It yields after the cutting balloon. And this is the more distal segment where it was quite fibrotic. After we do the treatment, we want to see what we've achieved, and we do the OCT run. So what you can see from the OCT run, and again, I broke it down for you. You see in the top panel, some nice treatment where we do have some dissection from the cutting balloon. As you keep coming more distally, actually, you're seeing slightly deeper and then even more, treatment. So you know that we've managed to fracture the calcium. We've managed to fracture the fibrotic segments as well.
Merva, can you go back to the last image just because it's interesting. Obviously, you show very extensive injury. But actually the calcium, you might argue, in that first top panel is a very large boulder of calcium. You can't see the deep wall. You can only see the luminal surface where you have that clear demarcation of intimal tissue into calcium. And so you mechanistically, you can understand that having blown up a balloon, that you've just created injury at the kind of shoulder regions of that plaque, which is why you see those 2 dissection planes. And you could then imagine that when you place a stent, that actually that calcium is going to move outwards, but actually you're going to get a greater stretch of the elastic portion of the vessel, which is from sort of 7 o'clock up to about 12 o'clock. So although you're right to say that there's been extensive kind of vessel disruption, the calcium might not be that disrupted. Whereas in the middle panel, obviously you've created a gap which may actually have been a plate of calcium that then has fractured. So it may be that you join the calcium you can see at 11 o'clock to the calcium you can see at 1 o'clock, and what you've exposed then is deeper tissue. So I think sometimes this is, I get really interested by this, and we'll kind of talk it through with the lab team as we look. I think the most important kind of message is that you did an upfront OCT, you've done some adaptation, you say with balloon and cutting balloon, but then lots of people will miss out that step of doing further imaging before they stent. And actually what you're demonstrating here is the importance of highlighting the adaptation, the modification that you have achieved. but dissection doesn't always equate to adequate preparation. So it may still be that we need to go back and do more. And I think that's slightly more nuanced and slightly trickier to be confident with. But it's just really interesting to look through those images in turn.
I agree 100%, and thank you for bringing it up, Tom. So this is what we mentioned last time in our previous episode where we focused on calcium. So remember, you do see the superficial, but unfortunately you get shadowing beyond it, so you really don't know the base, what's happening down here. So if it's going to yield or not. And that's where you still need to use a little bit of fluoro, and you need to use multiple orthogonal projections to kind of see it and kind of see where the wire is in relation to the balloon. So as you can see here, we're using the cranial shot to look at the distal segment and park our stent. And then we go to the caudal to try to optimize proximally where we park our stent. So we're looking at landing zones using fluoroscopy, and one is an areocranial, and then we go caudal, and we're trying to deploy the second stent in caudal. And now we've deployed our stent, but look at what we see. So I'm going to keep going, and I tried to freeze frame for you. So you do see the green part is, you do see some stent, then you don't see stent here where the red part is, and then you see stent again. So actually we had a gap. So you do see stent, you do see some expansion and so on, and you need to go through the usual steps, right? Where we're moving here from more proximal, our stent is nicely opposed and expanded, and we're all happy and yay, and we're moving. But then you get to, and we keep moving. And then if you don't go very fast and you slow down and you see this segment over here that I'm scrolling very slowly, there are no struts. So there's actually a gap. And then you start seeing stent struts again that are well expanded and well opposed. But this whole segment over here, you actually see an ugly dissection where we pre-treated the vessel, but there's a gap between this stent and this stent, right? It's over here. So this we missed with the naked eye because we used two different projections. We used the caudal, which foreshortened the distal edge because we were very focused on the proximal edge where to stop the stent proximally. And because of that, we were able, and then, you just keep coming back and you start looking more and more and looking at the distal edge of this stent. We have some contrast contamination here. So then what you do see is we ended up using stent boost, and stent boost did show the gap between the two stents that was picked up by OCT very nicely. We took a very short stent to, cover both segments. And you can see us here positioning the stent as well. And then we ended up deploying it. And then using the cranial shot to basically show you that we ended up getting this thing. Unfortunately, I didn't have the OCT run post was very contaminated, and I couldn't actually clear enough of the contrast, and I got a little bit worried because this patient had some renal dysfunction. But I think at least the takeaway from this particular one is that the first run showed us that we were expanded and opposed, but we had a gap. So we wanted to make sure we covered the gap, and so that's where I thought that we were okay saving some contrast. So Mukna, do you want to start going over some MCQs just to get the candidates involved with us?
Yep, perfect. I'll share here the file.
But while Mogne does that, do you use a pump injector or is it a hand injection for your contrast clearance?
We used Assist.
Okay, so that gives you a fairly standardized and clear clearance.
Actually, for me, sometimes I use hand injection. Sometime for left system, it's not perfect. Right, RCA, it should be okay. Yeah.
Okay. And what are your assist settings, Mervat? Do you vary it for the different coronary beds? So is it different for right and left?
Yeah, for left, I use usually 4 as flow rate, 12 as volume, and 400 for the pressure.
Yeah.
Right, I use 3 and 10. Sometimes I reduce the pressure to 350, and sometimes just I'll keep it 400, depending on the size of the vessel.
Okay.
Yeah. So we will do together 10 questions, and it should be interactive. I will show you a poll question, and you have to answer them. So this is the first question. What's the pathology? What can you see in this cross section? I will share with you the questions. I'm not sure I'll be able to share it while I'm sharing also the screen. I'll
So you're
stop.
wanting people to put their answers into the chat. Is that the plan?
Yeah, actually, no, I did actually a poll. Yeah, maybe because this
Okay.
is not maximized. Now you cannot see the slide anymore, isn't it?
No,
Yeah, because
no.
yeah.
No, that's disappeared.
So I'll do this, and so maybe can you help me for the poll?
Okay. The poll's just come up. Great. So
Okay, perfect. Yes.
yeah.
So okay, we have here 2 participants. Okay. Three till now. So maybe okay.
So we've got six attendees.
Okay, 6. So we have now 4 actual answers. I think we can end.
I think this is hard. It says, thankfully, it says hosts and panelists can't vote, but I think this is
Yeah.
really hard. Can we just be sure that the attendees can actually speak, that they have access to engage interactively?
4 of them actually answered.
Brilliant. Okay,
You can
perfect.
see now the answers. So one answered as lipidic plaque. And maybe I understand why they mentioned that, because that they are seeing that this area, which is has a diffuse border, and it is low backscattering and high attenuation. For calcified plaque, actually, you should have very clear demarcating border with low backscattering, which is not the case. The one who answered is the intramural hematoma. This is the correct answer. And why is that? Because you can actually see here almost the 3 normal layer of 360 of the vessel. And then there is a low backscattering area, which represent the hematoma within the wall. So this is actually a case of spontaneous coronary artery dissection.
Yeah, so just keep, because I think this is really difficult. And I think one of the lessons always from these types of quizzes is that it's very artificial to be asked to give a response to a single frame and out of clinical context. So
yeah. So
I think that the important things here are, as Mogn is beautifully described, is to think about what information you're getting from the light source from the probe, because that's truth, and it's then down to your interpretation. So I think you can justify everyone's answers, as you said. The lipid, so the classical feature of lipid is that attenuation, which you see very clearly attenuating, certainly from 1 o'clock down to 6 o'clock. From the luminal margin, you have a little bit of backscatter and sort of signal, and then beyond that you lose anything. So to consider that as lipid is not unreasonable. The calcium, again, you can justify because you say that you have to have a clearly demarcated border, and again, that portion from about 6 o'clock beyond the wire artifact up to about 8 o'clock, there's a small rim which is incredibly well demarcated. And similarly, from about 11 o'clock up to 12 or 1 o'clock, again, you've got actually a fairly well delineated margin. So you can justify that answer as well. I think the clincher is that there's that black band that extends most clearly from about 2 o'clock down to 6 o'clock, very close to the luminal margin, which is actually the medial band of the vessel. But oddly, the media isn't so obvious entirely in its circumference, which is the odd thing. But if you were to be toggling backwards and forwards through images, it may be more apparent. And then, as Magnus says, that's intramural hematoma. So the reason that you have attenuation in that space is actually because there's probably blood, and blood, in the same way as lipid, will attenuate the image. Now we've actually done some interesting work with a series of SCAD OCT patients where this is always called intramural hematoma, but there are actually occasions where the intramural space isn't filled with blood, it's filled with material that allows the light to pass. You actually can quite clearly demarcate the adventitial plane as well. And it seems to vary from case to case. It can depend on whether the artery is fenestrated or not, whether there's actually a defect in the lumen, allowing blood to move from lumen into vessel wall. But it's really that medial band that you see very close to the luminal contour that makes it most likely to be intramural hematoma. But I think this is a really tough question, a really harsh question to open with.
Yeah, I brought actually this just to for the audience to open their mind that usually the OCT image, it's like any image, you should have differential diagnosis. You have to correlate that with the clinical presentation. So for such patient from angio, actually, we thought that it's most likely SCAD from the presentation, but we have to confirm that we did the OCT. So sometime you will have findings such thing. You might argue with your colleague or even with yourself. Sometimes it might be a lipid. So you have to scroll up and down and see the rest of the vessel. But yeah, definitely you should have a differential diagnosis in your mind. Okay, so we'll go for the next question. Can you show the question, please? So here, what's the pathology? Most likely. I mean, yeah, you have only one cross section, but okay, we have two answers.
So there's still 6 people who can vote. So
yeah.
I mean, don't worry, the votes are anonymous, and it's just feedback for you. So there's no penalty in this, guys.
Okay, so maybe 10 seconds will end. It's 1 minute already. Okay, 3. Okay, so all 3 answered right. It's lipidic plaque. And here again, you can see that there is a bright area where then there is some low back scattering with the diffuse border and the high attenuation behind that. So this is a lipidic plaque, or we can say that it is fibrofatty plaque. For sure, it is not calcified plaque because in calcified plaque, as we mentioned, that you should have a well demarcating border. It's not intramural hematoma because we cannot see the normal layer, which is intima, and then the media band in 360. It's not the case like the previous one. And it's not normal. You cannot see the normal 3 layers. So maybe this is a bit easier. You can see that it's most likely fibrofatty or lipidic plaque.
Yeah, so the only other thing to signal is that you can, again, trying to look for normal structures. So one of the criticisms of OCT against IVUS is that in this setting where you have highly attenuating, so you can't see beyond the structure, so the lipid absorbing all of the light, is that we can't actually make out the vessel margin. But again, it's always worth trying to seek out some normal structures, and you can actually see the medial band extending probably from about 7 or 8 o'clock around to about 10 o'clock. And there's this black band.
Yeah.
So you can see actually that the OCT catheter is sitting against the vessel wall. And that's always an important thing to also consider when you're thinking about attenuation, is also about the distance that light has to travel. Now, in this case, actually, the lumen is remarkably small. This is a very high-grade stenosis if we looked at it angiographically, because you can see that the catheter and the wire take up over 50% of the overall lumen area. So there's very little lumen, in fact, for blood or contrast to flow. But you can see then that the media is quite close to the catheter at sort of 9, 10 o'clock. So you're looking at it only being about 500 micron, probably. We've lost the calibration markers, but you've got this thick fibrous rim, and then you can see the deeper structures in that quadrant from about 9 to 11 or 12 o'clock. But everywhere else, you can't actually make out where the vessel is. So you wouldn't be able to make any measurement of vessel size at this point. So it's a really important thing to recognize, because clearly, you're not going to be able to make a vessel measurement at this point, and so you're going to have to look for healthy margins in which to make your decisions around stent sizing. And the other consideration is around, whether this is at higher risk of potentially embolizing. So when you come to predilate this, are you at risk of then embolizing lipidic material downstream? So if you had a plaque like this, but you could make measurements, it might be the kind of vessel you think about direct stenting, is the other consideration from a procedural perspective.
Yeah. Perfect. Okay. So third question. What's the pathology? Can you see? So we have two. This is an area either proximal or distal. I cannot actually remember. To this one.
You're a tough quiz master.
No, this is, I think it's easy. Maybe I'm sure they will get that. Yeah. Okay.
Does anyone want to unmute and tell us what they see once we've seen the result of the poll? It's just quite nice to see people interacting with the images, really.
Yeah, perfect.
I think one of the dangers we have is we hold lots of these meetings and we all talk about what we see, and we're never quite sure that everyone's seeing the same thing.
Yeah. See any volunteer? You just open the mic and...
Should we see the result of the poll?
Oh yeah, I'll show it. Yep. And the poll. And share the result. Okay. So now we have 5 of the audience.
And we have a split between erosion and rupture.
Yeah. So any of those choose A can explain to us why he chose A? And then also from B, anyone?
If not, then I can explain why you've chosen A and B, because they were the two choices that you were going to have to toggle between.
Sure. Yeah.
No one wants to offer their opinion.
Sorry?
So clearly, yeah, go on.
Yeah, this is Dr. Adil. I chose plaque rupture with red thrombus, the second option.
Okay.
Yeah. And so what are you seeing, Adil?
Why is that?
I could see in the upper image that it's seems fibrocalcific walls with discontinuation of the order 3 clock. So in the second image, I could see what seems to be a thrombus with wide light scattering. It seems to be a red thrombus from this image.
Okay, good. Yeah, so I mean, you mentioned for the first image, you said fibrocalcific, and I challenge you maybe on the calcific, because certainly what you're absolutely right to highlight that there is disruption of the lumen that you see at 3 o'clock, this breach in the lumen. And again, one of the things that I was just mentioning in that last image, which wasn't so helpful because it was such a small lumen, is you have to consider where the catheter sits in the vessel in relation to lumen. So we can see that from 12 to 2 o'clock, the catheter is in very close apposition to the vessel wall, whereas actually opposite, sort of from 6 to 9 o'clock, the vessel's about 3 or 4 millimeters. So it's at its outer reach of how far the light can penetrate. And so actually the intensity of the scatter, which is very, very bright in that top quadrant from 12 to 3 o'clock, is partly due to the fact that the catheter is close to the wall in comparison to the intensity that you're seeing in the lower left quadrant of that vessel is simply a representation of the fact the light's traveling further and you're losing some of the energy in it returning to the catheter. But the most important element from that top panel figure is the disruption of the lumen. And then, Adele, what you mentioned about calcium, I think actually I would interpret probably as a breach in the lumen and then probably washout of the underlying material within what's most likely a lipidic plaque. And so you have this differential, again, a kind of not so sharp, but certainly a border on the under edge of the lumen of the dissected lumen, and then you see a back border, which is probably just where the material of the tissue.
Yeah, how about 7 o'clock area? I thought it's that like a small.
So again, because we're kind of at the outer boundary of where the vessel is. So no, the 7 o'clock. There's this. You've actually got an area with a slightly higher signal, which is right on the lumen surface. And if anything, you probably have some attenuation that's behind that. So what I always tell people, it's very difficult to do virtually, but is actually to draw in straight lines from the center of the probe. And if you draw a line in a straight line from the center of the probe down to the kind of lower margin of that bright area, you see that that's probably an attenuation shadow behind something that has a high signal that's reflecting at the very, very luminal surface. And so I can see exactly why you interpret that as a potential calcific nodule, but I think more likely it's something that's right on the luminal surface, which is attenuating and causing that kind of linear streaking behind it as a shadow. You see it a little bit across this very intense signal that you have on the lumen surface from about 10 o'clock right the way around to 3 o'clock. And again, if you trace in a straight line from the center of the catheter, you see that there's this kind of shadow that extends out in a line from the center of the catheter out beyond the scope of the catheter, beyond the scope of the image. So you're absolutely right, I think, to have voted for B because of the plaque rupture that's evident in the top panel. But for those that voted for erosion and white thrombus in the lower panel, then the lower panel is difficult because you don't really see plaque disruption. All you see is an irregular lumen surface that's likely to be thrombus adherent to a lumen. But as Adele said rightly, this is most likely red thrombus because the red cells within the structure are attenuating, are again absorbing all of the light. So you see nothing deep to the thrombus. The thrombus extends mainly from about 4 o'clock right the way up clockwise to where the wire artifact comes in, so 10, 11 o'clock. And you see nothing deep wall structure. So if you saw that in isolation, you just have to say that this was a thrombotic plaque event. You couldn't say it was rupture, you couldn't say it was erosion. But in combination with another frame that shows the plaque disruption evident, as you see in the upper panel, then this becomes a rupture plaque event with red thrombus adherent because of that attenuation, because of that light absorption.
Perfectly explained. So, question number 4. What's the pathology? Can you show the poll question, please? Yep,
Yeah, put
it's
this up.
there. Okay,
Again,
good.
I think it's difficult for there to be a right or wrong answer here.
Actually, they are excellent. All of them answered correct. 3 of them. We have excellent group. Okay, maybe 10 seconds and I'll end the poll. Okay. Okay. Dr. Tom, if you want to.
Yeah, so again, I think this is another lesson for interpretation of a single image is very, very difficult. So I don't know the right answer to this because without toggling up and down, I'm not sure. And I think you can justify all 3 answers that have been given. So I think one has said plaque erosion, one said plaque rupture and red thrombus, and the other has said calcified nodule. This, I suspect, is a classical image of an eruptive calcific nodule, but it can often be red thrombus misinterpreted as calcium or vice, so if it's red thrombus, then it may well be that you have anything underlying. So I think the interesting thing, so if we work from the wire artifact and 12 o'clock around clockwise, then you can see that the catheter is quite closely opposed to quite an irregular surface, and that you're seeing quite marked attenuation. So you see something on the leading edge, and then you see very little behind. There's a couple of, again, linear streaks heading out from the center of the catheter probe. And so that could be red thrombus. It's more classical of an eruptive calcified nodule just by virtue of the way that this often looks in terms of its pattern. It looks like then when you come into that gap between these 2 protruding nodules, like there might even be stent struts. So you see that within the tissue, there are 2 linear streaks, again, heading in a straight line from the center of the catheter probe out to the boundary of the image. And so whether that's a strut or whether that's something that equally has high reflectance. So there, and also at 4 o'clock, you see those 2 slightly smaller profile. Yeah. So cholesterol crystals can cause or they can cause a very bright reflectance. They often don't cause the attenuation. This is, I think, most likely to be stent struts within a failed stent with eruptive or protrusive nodule or thrombus adherent. And then again, you have this attenuating, protruding surface from 5 o'clock through to 7 o'clock. And then you can see that there's some fairly uniform signal intima from 7 o'clock round to about 10 o'clock with what seems to be a large strut buried within it that's causing that artifact. And then behind, you might wonder whether that's actually calcium, although the edge isn't very clearly demarcated. I would wonder whether this is in a very large kind of burden calcific lesion that you'd only really get a better appreciation of by scrolling up, scrolling down the vessel to better understand. That would be my interpretation, but I don't know.
So 100% agree. Most of the time, it's difficult actually to get the diagnosis from one cross section. You have to scroll up and down. Actually, this is from a vein graft. PCI done about 1 year ago, presented with non-STEMI, and this is what we found, that actually scrolling up and down, we can find that there is actually calcium. It's calcified plaque. and most likely this is a calcified nodule. You can see that sometimes you can interpret this as a red thrombus, which is actually mimic the red thrombus. Just looking for the area proximal and distal to that, it will help you to get a diagnosis, especially this patient presented as ACS, non-STEMI. The other thing, usually with the calcified nodule, you might get this shape, which is the lighthouse shape with a sharp angle. Usually you'll find it with a calcified nodule, while in the thrombus, usually it will be diffuse border hugging the wall. So this is actually it was a calcified nodule. We tried to balloon that with NC balloon. It didn't open well. Eventually, we get that with OPN high pressure balloon. Okay. Next question, question number 5. What's the most likely pathology? It may be difficult also, but here I give you actually the longitudinal view, the area distal and proximal to the lesion. So maybe you will get the diagnosis by exclusion. Okay, one answer. Good. 2. 10 seconds and we'll end. 3. Okay. Well, end that. I'm not sure, I cannot share the. Okay, perfect. Now we can share that. Okay. So, Dr. Tom, if you want to go through that, or I can go.
So we've got a mix, haven't we? So plaque rupture with red thrombus, and one saying an embolic event. Do you want to describe what you see? I mean, certainly I can. So we're working distal from proximal, distal on the left side, proximal to the right. So we just have to remember that with the Ultron, the new Ultron, as Mervat showed in her example, it was proximal on the left, distal on the right. So we see appropriately, if we compare the left-hand still image to the right-hand still image, tapering of the vessel from 60 millimeters at the pullback and 15, we see a large vessel proximal to a smaller vessel distal. And you appear to be representing areas of relatively normal looking vessel. Certainly in that area on the smaller panel on the left, you can see the intima media adventitia, certainly close to the OCT catheter from 9 o'clock up to 12 o'clock. And again, just reinforcing that point I made, because there's a little bit of blood within the lumen, and because actually the vessel from 3 round to 8 o'clock is about 3 or 4 millimeters from the catheter, you've got less resolution. So although it might at first glance look like it may be a kind of attenuating lipidic tissue, it's just that you've lost some of the signal just simply because of the distance of the catheter from the vessel wall. So that to me looks like a healthy margin. And then similarly at the top end, you're actually at the outer limit of what OCT can do. So again, the problem we have on the far right panel is that the catheter is sitting against the vessel wall. So you get good image quality again from 9 through to 12 o'clock, sorry, on the right hand, on the larger vessel right-hand panel. And then everything's a little bit fuzzier, distant, but that's just simply because you're at the outer limit of how far light will penetrate. So if we remember, unfortunately, the penetration of light is in the order of 2.5, 3 millimeters. So ordinarily, you're only going to be able to image a vessel that's about 6 millimeters maximum diameter. And this is certainly at the sort of 5 millimeter dimension, but the catheter's not sitting in the middle of the lumen. And so the real point of interest is this middle frame. And so the middle frame, again, consistent with the left-hand panel and the right-hand panel, from 9 o'clock to 12 o'clock, we see healthy vessel. And then what we see from 12 o'clock round to 7 or 8 o'clock is this irregular contour, which now appears more like red thrombus than that other example we had of calcium. And it seems to be red thrombus because, again, we don't see any deeper structures. So the red cells are absorbing the light, and that's what we see. And if you look at the longitudinal contour where the line, the yellow-blue line is set at the moment, if that's where we're looking at that middle panel, then it looks from the irregularity of the lumen profile like that thrombus might extend from about 32 millimeters up to about 50, 52 millimeters. So you've got a fairly extensive segment of thrombus. Now, I'm not sure. So I would say that B and D are reasonable answers to have given, because you can't see an erosive plaque, you can't see a plaque rupture, you can't see lipidic plaque. All you have really is red thrombus, which might be embolic, although it would be odd for an embolus to sit relatively proximal in a vessel, but it's not impossible. So I guess answer B is the most reasonable, but you can't see a plaque underlying it to say that there's definitely plaque rupture.
Yeah.
But the important thing is just understanding what you're seeing and to try and not to overinterpret it, but to just be going through it very systematically every time you look at images, I think.
Perfect. Yeah. So this is actually an OCT of a guy in his 30s presented as STEMI, and this is LAD. He was in 30s, has no risk factors. The TIMI flow was 3 already in LAD, so we decided just to do an OCT, and this was the findings. When we saw that the area distal and proximal to the lesion, it was free of significant plaque. So we decided just to keep the patient on anticoagulation, dual antiplatelets, and stop. Then we thought about it could be embolic event or any other reason. From the lab investigation, we found that the platelets was very high. So we consulted hematology, and eventually the patient diagnosed as essential thrombocytosis. They did even a bone marrow biopsy, and they confirmed the diagnosis. The patient started on management from them. We brought the patient after 2 months, and we repeat the angiogram. And we did also OCT, and this is the OCT after about 2 months. You can see that the area distal, it's almost normal. There may be some thickening of the intima. Here, the same, and also the proximal, but I don't think there is any plaque burden that can explain either plaque erosion or plaque rupture at the time of presentation. And already we have an explanation from the hematology diagnosis, which is essential thrombocytosis. So it's not all ACS cases, it's either plaque rupture or plaque erosion. We have to think about other possibility, either embolic or even thrombosis in situ, like this case. Question number 6, what does this cross-section show? Can you show the poll question, please? Yeah. Okay, by the end of 1 minute, I will stop. Okay. So it's distributed among all choices. What do you think, Dr. Tom? Is it normal healing or there is any stent failure?
Yeah,
or
so I mean, clearly there are stent struts out there. So if we're then looking, so you don't necessarily see struts fully circumferentially. So we see stent struts that are certainly evident from about 4 o'clock. Some of them have got a mark on them that highlight where they are, which I think is the software actually acknowledging the stent struts. And a really important thing there is to understand what the software is doing, because sometimes the software can mislead us. So there's a lot of talk about artificial intelligence and how that's going to dominate helping us in terms of our decision making, but it's not perfect by any means. And so it's really important to understand both looking at an image and then interpreting how the software has also interpreted. So in this setting, it has rightly identified 5 struts. We see white dots across 5 struts, but it's then missed struts beyond. If we go continuing clockwise from where Mogne is, we can see there's another one certainly with a nice streaking artifact behind it there, and another one up about 9 o'clock. And there are 2 or 3 further struts evident, and then another one around about 11 o'clock. And there may well be, from the purpose of the attenuation, be another one at about 1 o'clock. Okay, but it hasn't effectively identified all of those struts. Now, at the same time, the struts can appear differently depending on the way that the light reflects off them. So again, whether you're close to the imaging probe or far away from the imaging probe, and if the light's hitting at an incident angle or it's hitting en face, it's going to change the way in which the struts look. So again, that's quite an important thing to consider. But I think everyone's happy to identify that there are struts within this vessel. So then, is it neoatherosclerosis? Is it new intimal hyperplasia? Is it normal healing? Well, again, that comes down to interpretation. So I think what we can see is that the struts that are readily identifiable from 4 o'clock, 5 o'clock, clockwise around to 11 o'clock, that actually there's very little in the way of tissue between the lumen and the stent struts. There's not absence of tissue. You might argue that the strut that's at 7 o'clock and 7, 8 o'clock that are very near to the lumen surface, you'd have to magnify that up to see whether there's any obvious tissue over it. But I think this probably represents just normal healing of a stent. So in terms of neoatherosclerosis, do we see lipid? Do we see calcium? Well, there probably is, there is calcium that you might be identifying from about 11 o'clock round to 1 o'clock. There's certainly a kind of well demarcated zone between the intimal tissue close to the lumen and then some deeper structure. And where the cursor was there, there's a hint of there being a back wall to it as well. So I wonder whether that might be calcium, but most likely that's actually behind a previously deployed stent rather than new atherosclerosis inside the stent strut. But I can see that you might have identified calcium there. And then the only other area where it's slightly more ambiguous is from sort of 12 o'clock, 1 o'clock round to 4 o'clock, where there is this arc. Now, interestingly, we're increasingly interested in the dynamic nature that patients develop plaque or develop intima or actually develop kind of layering of plaques. And so it may well be that this was where there was adherent thrombus on a stent strut, which has then become endothelialized. So that slight eccentricity to the tissue response within the stent struts may well just represent the way in which this vessel has healed. But this certainly doesn't look like an exaggerated intimal hyperplasia or evidence of neoatherosclerosis. I don't think there's lack of healing, because I think those 2 struts towards the lower inferior quadrant margin have probably got coverage, but you'd have to magnify that up. So I think the most likely answer to this would be A, normal healing of stent, which certainly 40% of you went for, but you can argue the others by virtue of how you interpret the imaging. And I think this isn't about right or wrong answers. I think the purpose of doing this, and it's really important, is to see how different people look at the images and how you interpret the images. And so it's not just about getting an output, having an image that looks pretty. It's then about having the confidence of interpreting what you're seeing and then how you work on it. So this kind of process is really important, actually. And I think hopefully develops then your confidence in terms of how you use the imaging to your advantage during a procedure.
Perfect. Okay. And question number 7. What about this cross section? I have 5 answers, so 5 seconds and we'll stop. Okay. So Dr. Johnson, they are actually half of them, or 40%, 60% between new atherosclerosis and new intimal hyperplasia.
Yeah, and so I mean, I think you can justify again both of those answers. So the difficulty. So again, new intimal hyperplasia. So we're in the same scenario we were in earlier, where we have actually quite a small lumen. So the catheter and the wire take up quite a lot of the luminal space. And then what you can see confidently is this very homogeneous, this very uniform signal with high reflectance. So it's bright yellow, but you can see deeper wall structures. So you're all absolutely right to highlight that there's intimal hyperplasia. This is classical fibrous tissue. And then because this allows the light to penetrate, then what you can see behind are stent struts. So we see that there's a strut clearly at 1 o'clock, quite a broad strut with attenuation behind it. Another clear strut is at about 7 o'clock and another at 8 and 9 o'clock. And then the difficulty you have is that there then is a kind of heterogeneity. There is a difference in the signal that's evident behind that area of intimal fibrous tissue. And so the question then is, what is that? And I think that is then down to interpretation. So sometimes around the struts, certainly of the earlier generation drug-eluting stents, you would see actually a kind of fibrin response. Now that tended to be a kind of darker dropout that you would see that was kind of just pooling around the stent struts, which seemed to be a kind of inflammatory response to the stenting. What I would interpret here is that this may well be some attenuation with lipid. And so although you see the struts, because the struts are very bright reflecting material, actually between the struts, so certainly from 2, 3 o'clock round to about 7 or 8 o'clock, the deeper wall structures have gone. Certainly the attenuation is very significant from sort of 2 o'clock to 4 o'clock. You see that fuzzy loss of any deeper tissue. And in fact, you can't even see stent struts evident in that quadrant. And so that to me suggests that this is lipid deep to a thick fibrous plaque. So I would be erring towards neoatherosclerosis rather than simply neointimal hyperplasia in this case. Dr. Moser said, I think the time frame is important. And I think that's very reasonable. So, we'd expect neoatherosclerosis to develop 12 months or so beyond. So if this was an early response, this was in the first few months, then you're absolutely right. I think you would interpret that area around the strut to be more likely an inflammatory response in the context of a very aggressive neointimal hyperplasia. So the timing, I think you're right, is right. And yeah, as Mervat says, the two aren't mutually exclusive. And it is somewhat academic, so I wouldn't get too lost in those interpretations. The fact is that this is, I mean, the important thing in the setting of in-stent restenosis or stent failure is the use of the imaging to define the mode of failure. Is why has this stent failed? And I think that's what's so important, is actually identifying. So the first thing I'd be doing here is usefully having a stent strut that's evident at 1 and a stent strut that's evident at 7, is I'd be immediately be making a measurement of the stent diameter, because by far and away the commonest driver for stent failure will be stent under expansion. And so when you then make measurements of the true vessel size in relationship to that stent, you may well find that the original stent had simply just been too small. And that's what's then driven the failure. So for me, the role of the imaging is to be confident or certainly to guide us or aid us in understanding why this patient has failed their stent, because you want to know that before considering the deployment of further devices, further stents that may well then fail again in the future. Is that the last of your questions, Agni? Oh, we frozen. Can you hear me?
It seems he's frozen. Do you want to?
Yeah. So shall I share if I can, I'll share the final presentation.
Actually, your voice, Dr. Johnson, is interrupting.
Is it? Oh, sorry. Is it any better now? Are others having the same problem?
Sure.
Tell me, so I know you can see this screen. So obviously this is the third in the series, and I'm really excited that next week is SAS's studio, and I'll be traveling to Jeddah to hopefully meet some or all of you, I hope. And so this third webinar, as Mervat's already highlighted, is around this idea of PCI optimization, and actually fitting very well with Mervat's case and with the quiz that we've just done. I'll share with you just a case from last week, actually, or from just before Christmas, that came back last week, which I think is a useful one. So this is actually a patient who presented the first week of December as an anterior ST elevation infarct. And I don't have very much in the way of clinical detail, because actually this is all about the kind of angiographic assessment and the procedural decision making. So this was undertaken as we normally would, a 6 French right radial approach, took a diagnostic shot of the right, and you see a large dominant right coronary artery with some disease. So we do see some disease in a large posterolateral branch, some diffuse disease in the PDA, and then importantly backfilling of the LAD. So we see some collateral filling of the distal LAD. And a EBU35 guide is taken directly to the left, and that confirms then proximal occlusion of the LAD. So we wired the LAD with a Scion blue, a small predilatation, that's just a 2.5 balloon. And there we then have recanalization of the LAD very promptly. We see a slightly late filling diagonal branch. So this is where we're at. I guess, it'd be nice to hear from one of you as to, is this a case where you would be taking imaging up front, or do you just get on with your procedure and stent? And if so, then how far do you anticipate you might be stenting? I don't know whether anyone has any comments on that. Anyone?
Yes, so this is him. So we see a diffuse disease in image after post dilatation. We can see after restoring the flow, we can see a diffuse disease in the LED up to the metadistal segment. So I would rather do imaging before stenting.
Okay, yeah, I think that's a fair justification. I mean, the reason for showing this is actually because we live in a difficult healthcare environment where I don't think we can justify imaging every case. And so although my imaging rates are very high, actually in this case with my fellow, I said, we're just going to carry on and do this angiographically. And so that was the purpose of kind of just pausing at that point. And actually we then went about a historical practice of I was going to wire this diagonal branch and taking a wire down to try and make a length measurement. And I have to say at this point, the fellow was scrubbed and I was sitting in the back, which is never a brilliant way to do a procedure, with me kind of backseat driving. And so I said, well, actually, I'd probably go shorter than the 30 mil length here. And let's just treat discreetly from the proximal AD to just around this bends. We'll take a 28 millimeter stent. But I think, Noof, as you've highlighted, there is quite extensive disease. And actually, Tim, the fellow, had said, oh, well, I don't know, maybe I'd go 38 or maybe even 48 and cover the whole length. So there was an uncertainty. And I think that does demonstrate an interesting transition that we will have to face, where the more we adopt imaging, actually, the harder it becomes to make decisions based on the angiogram. So at this point, we elected to take a 3 by 28 millimeter stent with then upsizing of the proximal vessel and with a 3.5 balloon. So there's the 3028. And that's how it looked immediately post stent deployment, so before any post dilatation. So there's still flow in the diagonal, which has this jailed wire in it, although it seems a little bit pinched at the ostium. And so we see that there is just a slight discrepancy in terms of the distal edge. So if you wanted to take imaging before, I guess you're wanting to take imaging now. You happy with this? Okay, so I went about, I wasn't happy with it, but before it, again, this is about trying to then rationalize the decision making during a procedure. So I asked for the team to bring the OCT so we connect up the pump so that we can do an injection. But before doing that, there's no harm in actually trying to optimize your stent as you would ordinarily, because the information I'm going to get from the OCT I know is going to tell me I have an underexpanded proximal stent because we haven't yet post-dilated. And actually, because of the pinching of the diagonal, I'm feeling very likely to want to proceed to a kissing inflation into the diagonal branch. So actually, it makes sense to firstly optimize the stent that's in situ. So I take a 3.5 NC as a proximal optimization. So that's down to the level of the bifurcation. And then actually rewire the diagonal, so that then the first OCT run I take will assess the distal edge and tell me if there's a problem that the angiogram was suggesting. It will tell me whether I've crossed my wire on a distal cell cross, and it will hopefully tell me that I've done enough to optimize the proximal edge of the stent. But had I just taken the imaging because I was focused on the distal stent edge, I'd have lost then. I'd have then definitely had to have gone back and done further imaging to optimize and make further decisions. So it's just about rationalizing the timing at which you do things. So this is the point at which we take the OCT. So hopefully now I can convert across to the other laptop. Let me just see if I can share for you that. So hopefully now you can see, let me stop sharing this. Just see. So I'm hoping, yeah, great. So this is the first OCT run after that rewiring. And you can see, so this is Ultron 2 software. So it's slightly different. Again, it's formatted using the Ultron platform, which you can see morphology, sizing, deployment, review. Actually, the iterative change has been that it's given you this ability to switch to what's called a flexible mode. So this is actually how it comes. I'm sorry that it's not anonymized. So we see here then the angio co-registration. We've identified an area here, a region here, which is on the distal edge of the stent, which is then apparent on the angiogram. And so the first thing that we were interested in was, has there been, and I'll just remove the contours, has there been any distal edge injury? So what do people think about this? Does anyone want to talk through what they're seeing here? Extending from what Mervat presented to us a little bit earlier on. So what would you think of this dissection? Is this a dissection that needs treatment, or is this a dissection that you're going to be happy to leave behind? Anyone want to say?
You can either open the mic or you can write in the chat.
So we can see then we're on the distal edge of the stent. As I scroll downstream, so distal to the vessel, you see then quite a significant dissection, okay, which is coming off the edge of the stent. So then, as Mervat highlighted, we want to think, does it extend more than 3 millimeters longitudinally? Does it extend more than a 90-degree arc? And does it extend into the media? Now, the media is difficult because we can't really see the contour brilliantly at this point. So I think let's park whether it goes into the media or not for the moment. Does it extend over 3 millimeters? Well, the stent edge is here. And so if we wanted to make a longitudinal measurement, then we'd measure it from the stent edge, which is this point. And we see it continue. It seems to just about normalize there. We're at 3.8 millimeters longitudinally, but actually we see more disruption at around 12 o'clock, and we see actually continuation of the dissection there. So this actually extends really quite a long way. We see it still extending there right the way to about this point here. So it's about a 12 millimeter dissection. It's really quite profound, and I think that in many ways reflects Knuth's interpretation of this being very diffuse, high burden disease. Now, the other important thing to consider here is actually what are we seeing at this point, because this is quite a classical appearance of the catheter sitting eccentrically within the lumen, so sitting against the vessel wall. And actually what we probably have here is just blood that's hugging the catheter, which tends to hug the catheter and wrap onto the luminal surface. So we've got an appearance here where we actually aren't clearing blood perfectly from the vessel wall. Now, in terms of medial engagement, it looks actually like we probably do come down into the media in terms of the dissection here. And we have certainly 90 degrees, if not more, quadrant of injury. So the dissection probably extends right the way around, almost 180 degrees. So this is an important dissection. Now, often, actually, the rule of thumb is that if it's evident angiographically, it's going to be quite significant by OCT. So the fact that there was something already not right here, I think, made this very likely to need coverage. And so this leads to us having to treat more distally. So then the important thing is, well, we now have information that enables us to make appropriate measurements. You can see actually here, I've made a measurement of vessel size. Sorry, just try and get it on the frame with the measurement on it. And so I've identified the media. So you see the media extending here. Although there's intimal hyperplasia, there's intimal thickening, you can actually see the vessel wall. So EEM to EEM is measuring 3.4. So you'd round that down possibly to 3. Although I'd be very cautious here because there is still plaque. If I place the lumen contour on, then we can see actually we're getting a luminal measurement of 2.4. So although you're told by the kind of Illumian criteria often to gauge it by downsizing from the EEM, I will sometimes toggle between the lumen and the EEM, and where there's quite significant discrepancy. So here you've got a lumen that you'd upsize to 2.5, and you've got a media that you'd downsize to 3. That's quite a significant discrepancy. if we look at the dimensions here, we can see that we have a luminal measurement. If I can pick out those measurements here, it's not giving me the minimum maximum, but you can see here that we have this significant differential. So I'm going to be looking to cover, certainly in terms of, there is no real healthy vessel, so this becomes more challenging, but you're certainly looking at having to cover that area of dissection and probably come down to that area where I made my measurement. So you're looking at this being 15, 16 millimeters of stent that you'd want to cover that area with. So I'd take a 275. I'd go somewhere between the luminal and the external elastic membrane measurement. So the other thing we can do, though, while we're still here, is we can then also check how well we've done on the proximal edge of the stent and whether that rewiring of the diagonal was appropriate. And actually what we can see, if we just bring this up just to focus on the stent, is this is giving us in a tapered mode measurement that we have a minimal stent area of 5.7 on the distal edge. The proximal edge is 13, and this is well expanded. Now, the beauty of this is that you can change the mode. So if we just bring this to tapered mode, sorry, if I bring that to dual stent mode, why is that not working? Let's just, sorry, for some reason it's not giving me the it's not identifying the, let's put it in review. Here we go. It's just in the review mode. Sorry. So this is then telling us that if you divide it into half, then we see that the luminal area is picked out the segment. We take it from here. We can see quite clearly on this still frame, we still have marked malapposition of our stent struts. And actually this vessel is measuring closer to 4 millimeters. So certainly in one plane, this stent needs to be expanded to 4 millimeters, where I'd taken a 3.5. And it's suggesting that we have under expansion at this level of 60% expansion, which is 6.6 millimeters squared compared against this proximal reference. Now, distally, you've got 95% expansion with an MSA of 5.3 against a distal lumen of 5.6. The distal half of the stent looks all right. And then the only other consideration, I'm sorry to bombard you with information, but is then to look at the 3D mode to consider then that wire cross that we pass. And you'll see that this new software creates really very beautiful imaging. Let's just check that we've got both the guide wires evident. So if we want to just look at that cross, I can just close this up. Now we can run through. And so if we look at where that wire crosses into the bifurcation, sorry, the wrong way. So it's not so easy to do on the laptop. Rotate that around the other way. Then that wire gives the impression, although it's not brilliantly identified here, as a relatively distal cross. Let me just open that back up again. Just see if I can, that shows it better. So we can see here that actually we've got actually a linker falling across the ostium. And so although that might be a fairly distal, or here might be fairly distal, it's difficult to get a preferential cross at this point. So I'd be happy accepting this as being reasonable for reopening the side branch as and when we come to do it. So let me go back to what we did. Sorry, I can see there's something in the chat. Yeah, it needs treatment. Okay, fair enough. We agree. Thanks, Sally. Let me just share my screen again. Danger of trying to multitask. Can you see? You see, let me stop sharing on here. Yeah, okay. So hopefully then you can see we're back in that presentation. So I took a 2.5, not a 2.75, 16mm stent. And that is then just being cautious in terms of identifying there's so much downstream disease, just not wanting to oversize. So if you remember, it was averaging at 2.3. And so actually going to 2.5 just reduces the chance of vessel injury. But acknowledging that the vessel is actually much bigger, so going back with a 3.0 NC within the margins of the stent. And you can see now, having been confident in where that wire crossed into the diagonal, I've then taken a balloon down the diagonal, and to perform a KISS with a 3.0 and a 2.5, a 3.0 non-compliant in the LED and a 2.5 semi-compliant in the diagonal. And then, having identified that there was still malapposition proximity, have gone with a 4.0 NC balloon. Okay. And so that's how it looks angiographically. So we've still got TIMI3 flow down both vessels. That ambiguity around the distal stent edge is gone, although we acknowledge there's still disease distal. Now, I'll show you both of the OCT runs in sequence, because actually what we go back and it's how we go back and respond. So let me stop sharing that and share again on the Ultron. Sorry, this is a pain for toggling. So this is the second OCT run, which will hopefully be coming up. Looks like I need to share again.
There is one comment from
Yep.
Adil, Dr. Johnson. He mentioned that there is a thrombus at the edge, at the distal edge. Even without significant dissection, shall we stent that?
On the distal edge of the angiogram.
Previous,
Or
yeah,
so,
the OCT,
so there was,
yeah, the previous run.
so
Yeah.
that previous run, there was thrombus at the there was certainly thrombus adherent to the struts at the proximal edge. Obviously, at the distal edge, we had the dissection that we were going to cover with stent. So we'll come
Exactly.
back. That may well be relevant. So this is now that second OCT run. So having extended the stenting with that additional 16mm, having post-dilated with a 4.0 and having kissed into the side branch. So actually, now we can, if we look at the distal, I always just take the eye off because it allows you to identify the lumen. We do see that there's disease. So we see the media, we can see the media extend around to about here. And this is relatively healthy, just with a little bit of intimal thickening. But then we see a plaque that extends from about 2 o'clock around to about 6 o'clock. But we expected there to be disease. And so that stent has landed into a disease segment. But importantly now, and having size to the lumen rather than size to the vessel size, we have avoided any further extension of dissection. So the outlet of the outlet of the stent looks okay. If we come up to the side branch, so we do see that there's some, you can see the overlap of the stent. You can see 2 layers of stent struts here and up here. And there is actually just a little bit of malapposition due to the eccentric nature of the vessel at that point. And then we should see the wire of the bifurcation. So here we see, this is the point of the bifurcation. And so you can still see, as we might have anticipated from that 3D, that there are some struts hanging distally, but actually it clears quite well. So the ostium to the side branch opens quite nicely, and you'll then see this is the diagonal wire coming into field as we then come into the more proximal LED. But then most disconcertingly, there's actually quite a lot of material within the lumen. So here we now see material in the vessel. And one of the things that Mervat highlighted in our cartoon of stent optimization was awareness of tissue protrusion and thrombus. And so the question then is really how you manage this, because what we're seeing here is this irregular lumen contour, which is representative of the lipidic plaque that the stent has landed into, and then protrusion of both tissue and, due to the acute ST elevation nature of this, also thrombus that we can see then protruding into the vessel wall, into the lumen, sorry. So the question being then how you go about dealing with that additional protrusion. And again, here you can see still there's a little bit of malapposition, and there is tissue adherent to these struts. Now, this patient had been preloaded with ticagrelor, was on heparin, ACT guided heparin, but hasn't had anything more than 180 milligrams of ticagrelor and 70 to 100 units per kilogram of heparin. But we can see certainly evidence of thrombus. But I guess most worryingly, we see this intraluminal material. So I don't know what people want to do about that. You just stop sharing again. I'll come back. So is there a comment in the chat? Seems there's thrombus at distal edge even without significant. Okay, yeah. So let me share the PowerPoint presentation again. So what are you going to do now? So I went back and I post-dilated. So I took the 4.0 again proximally to see whether we could disrupt that material, and also to ensure that we got apposition of the proximal stent. I don't go near the bifurcation again. And actually in this spider projection, we see, although there's slight haziness at the diagonal, we've got decent flow into the diagonal branch. And so I can then show you finally the OCT. I'll show you what the phone, let me, sorry, this is, let me go back to the OCT. So this is the third run. I need some form of dual screen presentation. It's beyond the scope of Zoom, sorry. So this is then the final run. And actually, rather disconcertingly, it shows even greater amount of tissue protrusion. So if we come up to that area proximal to the bifurcation, so there's the diagonal. And you see actually, if anything, more material around the level of the bifurcation. And then in that area more proximal, we see even more tissue. And the stent struts, if you notice, the stent struts, this is an acutely deployed stent, but the stent struts are deeply buried behind this tissue. So evident of the fact that this, is soft tissue that the stents are just kind of passing through. I won't go back to the, well, I will go back to the presentation, but how are people going to want to deal with this? So this is really quite impressive material. Mogni, I don't know, what would you want to do with this?
Actually, I don't know exactly, because sometimes we have it, especially in ACS patients, but I tend to, if I have TIMI3 flow, just I leave it. If it affects the flow, I'll try to balloon it more.
Yeah.
Just either to oppose that against the stent or to dislodge that material. If not, and still having a slow flow, I might go and put another stent.
Okay. Let me just show you the 3D is actually quite nice here. If I again close that off and fly through, you do get an appreciation again. So here nicely you can see, so this shows really beautifully how the stent struts, which all have been freshly deployed, so should all be evident on the luminal contour. You can see how these struts have become buried under the material. So you just see how all of that tissue is burying it. And then nicely you can see the wire passage into the diagonal. So we can see, if you compare that to the very first run we had of the bifurcation, that actually that's open, but we saw on the still frames that there are still areas of tissue or thrombus adherent to the stent struts. But actually here, I think the 3D can be quite useful. Again, you just see this protrusion of the material within the vessel wall. So let me stop sharing that. I'll go back to the PowerPoint presentation. So I'm conscious we're running out of time. stop sharing. Share. So, yeah, my interpretation was, well, you know, do you further postulate? Do you thromboaspirate? Do you try and retrieve it? Do you use pharmacology? So in this sense, a glycoprotein 2b3 antagonist, or would you consider further stenting? And I think it's very reasonable to consider the flow. And actually, although the flow is probably TIMI 2-3 flow in the LAD, there wasn't anything obviously apparent angiographically. I mean, there's a slight haziness and intrastent filling defect, but nothing much. I actually felt that with the last post-dilatation, if anything, I'd made things worse, and I was just prepared to leave it. I guess the only question then is, what do you do next? So do you bring this patient back as an inpatient for further assessment? Do you just accept that's the result and leave it be? Do you think about interval imaging? I don't know whether anyone has any comment on that. So would you bring this patient back, Mopney?
Actually depend on the clinical situation. If the patient continue to be asymptomatic improved, is the elevation improved, I'll leave him alone just to take it and that's it. Yeah.
Yeah, so this was, as I say, this was actually only in December. I have to say, for me, this was really quite marked thrombus protrusion. And a lot of my colleagues that would actually bring this patient back as an inpatient. And I don't see a huge advantage in bringing patients back early, because I think it's very likely you're going to continue to see defects. So the timing of bringing someone back, I think, is quite important. So I brought this gentleman back last week. So 4 weeks, I gave a 4-week interval. And so this was last Thursday, and this is the repeated angiogram. He's been fine. I'm electing to treat this complex diffuse circumflex disease by symptoms. So I'm not going to embark on intervention on this unless he's symptomatic and he's been symptom-free. The right coronary, if anything, looks slightly better in this convalescent angiogram compared to the index procedure. And this is how it looked, the left system looked angiographically. And so I'll just finish by showing you the OCT on the Abbott system. So, load. So this was last week on the 4th. So we've got 2 runs just because we didn't quite get the proximal edge captured on the first OCT run. And obviously this incurs a cost, but I think it is useful just to better understand. So here we are at the distal, so there's the distal edge. And so actually we see a very decent area, close to 6 millimeters squared, 5.9 millimeters squared, with nice early healing of that stent. We did see that I'd left behind a couple of areas of malapposition, and here we see still, just due to the eccentric nature of the vessel, that there are some areas where still there's gaps behind the stent, but again, a very decent lumen. But importantly, actually, you see that these struts have been covered. So we can see, if anything, this might be thrombotic material that will then endothelialize, if not already. And then here we see the double layer of stent struts. And so again, this is in an early phase of healing, just within 4 weeks. Here's some further malapose struts, but actually with what appears to be tissue adherent. And we come up and have a look. There's the bifurcation that we have post-dilated into, where there was all that material, and that material now has cleared. So that's an important consideration from the before and after. And then where all that material was intraluminal, actually all we're left with is this early kind of healing response, very much like that image that you had on your quiz, Mopney, of just some early material covering these struts, with a couple of struts closer to the luminal surface. But I think, and again, here you see this slightly more irregularity here, which may well be the healing of that. And certainly there aren't a huge number of struts. You ask about discharged on anticoagulation, no adults. So this patient was sent home just on aspirin and ticagrelor, no additional anticoagulant therapy. But I think it's really interesting to see a month down the line how that's healed. But I think it does highlight that actually of all of the different elements we have to consider in optimization, that actually tissue or thrombus protrusion, I think, is one of the hardest for us to consider managing. But I just thought that was quite a useful case to have arisen last week, fortuitously before our webinar this week, to share with you. But I don't know if there are any other comments on that.
Perfect. Actually, it's amazing how it's within just 4 weeks the stents start to be healed. That it's actually give us some of confidence that if we need to stop dual antiplatelets and just continue single antiplatelets in a patient with a high risk of bleeding, we can consider it. With these imaging, actually make us understand the healing process better.
Yeah. Good. Well, I hope that's been useful. I've really enjoyed the last 3 sessions that we've had. I really look forward to meeting as many of you as possible next week for, again, I hope some interactive sessions on imaging and beyond. If there aren't any other questions or comments to make from the group, then I guess we finish up here. And just lastly, to say thank you to the Abbott team for having coordinated this, because it's a really important opportunity for us to case share and to continue our learning and confidence really in engaging with OCT imaging and intervention. It's a really exciting space to be in.
Correct. It was amazing, Dr. Johnson. It was an amazing group, and hope to see you all in SAS Studio.
Great. Thanks, Magni. Thanks,
Thank
you so much, Dr. Tom, Dr. Mokna, and Dr. Mervet. Definitely thank you so much for the effort for this webinars. It was really interesting, and hope to see you in Jeddah.
Good. Thanks, you.
See you.
Thank you.
Okay, bye.
Take care.